Thank you for the opportunity, organizers and everyone. I'm going to just discuss in brief how to diagnose, what is a LISFRANK injury and how to diagnose it. So why LISFRANK? It's a very broad term, and by this we mean it's an injury to both bony as well as ligamentous injuries to the tarsometatarsal and the intercuneiform joints. Actually, it was described by, it was not described by Jacques LISFRANK as we would tend to believe. He described the joint and he described the amputation in the 17th century, but it's commonly referred to as the LISFRANK's injury. What is more important is 20% of these injuries are missed, and the prognosis and the outcomes of LISFRANK's fracture dislocations are quite overestimated by the treating surgeons. And overestimated meaning they are quite optimistically estimated, and if they are not picked up and treated correctly, it can lead to some disastrous outcomes, as we'll see along the course. The mechanism of a LISFRANK injury is usually excessive loading on a plantar flexed foot. So we are going to see all the plethora of these injuries in this tarsometatarsal joints and the intercuneiform joints. All of you are familiar with the three-column theory of the foot. So the medial column is the medial cuneiform and the first metatarsal. The middle column is the lateral cuneiform and middle plus lateral cuneiform and the second and the third metatarsal. And the third column is the cuboid with MT4 and 5. Any disruption in these three columns at the tarsometatarsal joint will lead to a LISFRANK's fracture dislocation. Now all these columns and this joint complex, the midfoot complex, is kept together, held together by these three important ligaments. One is the dorsal ligament, which is from C1 to M2, the intraosseous LISFRANK ligament, which is the strongest, and the plantar ligament from C1 to M2 and M3. The weakest ligament is the dorsal ligament. The strongest ligament is the intraosseous ligament. And the plantar oblique ligament is also a strong ligament which keeps all these joints intact. And because the dorsal ligament is weak, when you have, so this is a model, plantar C1 to M2, 3. This is the important ligament which we see here, and the dorsal C1 to M2, and the intraosseous, like this. Because the dorsal ligament is a weak ligament, when you have a hyper loading of the plantar flexed foot, usually it is a dorsal displacement of the metatarsal basis. There are multiple classifications. Unfortunately, no classification is useful for treatment guidelines or predicting the prognosis and outcomes. So you have the most functional, the most commonly used, which is the Hardcastle and the Meyerson's classification, where you have a type A, which is a complete homolateral, either medial or lateral, or dorsoplantar. Type B, which is partially either medial or partially lateral, and a type C, which is a divergent dislocation, so either partial or a totally divergent displaced. So this is just a theoretical classification. It does not really predict any outcome, neither does it give us a guideline on treatment, because even subtle inconsistencies or incongruities may end up with surgery. So this is type A, B, C in the CT. What is more important is how to diagnose it, and that is the gist of the talk today. The most important sign is the midfoot ecchymosis on the plantar aspect, especially quite well seen in a clean foot. So you need to clean the foot before you can see it, especially in dark-skinned people like us. A single limb rise, if possible to be done, is painful at the tarsometatarsal joints. You can palpate the tenderness on the tarsometatarsal joints and also do a piano key test by depressing the metatarsal basis. Curtis described a passive pronation abduction test to be done like this, and it can give you a clue as to a subtle LISFRANK ligament injury if there is pain at the tarsometatarsal joint. One must also look at the presence of a compartment syndrome of the foot in such injuries. Not very uncommon. Radiology, multiple radiological markers have been described. So all of you know, in the AP view, the medial border of the second metatarsal is continuous with the middle cuneiform, medial border of the middle cuneiform, and the intermetatarsal space, first and second, should be equal to the space between the medial and the middle cuneiform. Unfortunately, most of the non-weight-bearing films may not disclose these subtle instabilities, and therefore you need to take weight-bearing AP and lateral views and the oblique views also at times. So if you see this, this is what becomes evident. The medial border of the second metatarsal and the middle cuneiform becomes evident on weight-bearing. Look at this. The X-ray on the left is not showing anything, but it becomes very evident when you do a weight-bearing AP film. Non-weight-bearing and full weight-bearing, see the difference. Widening of the LISFRANK's interspace, more than 2 millimeters, or you can also look for a flex sign at the base of the second metatarsal in the AP projection. An oblique view, in the oblique view you should look for the lateral border of the third metatarsal is continuous with the lateral border of the lateral cuneiform, and the medial border of the fourth metatarsal is continuous with the medial border of the cuboid in an oblique view. In the lateral view, again, the metatarsal basis and the cuneiform dorsal aspect should be continuous, but like I said, what appears continuous may not be so when you do a weight-bearing lateral view. So what is a correct X-ray? It is actually a 20-degree craniocaudal angulation that improves the visualization of the TMT2 joint, tarsometatarsal joint.
Quick wrap up, sir.
Yes, almost at the end. Also, the CT beam should be perpendicular to this joint while you're doing a CT scan. CT scan is obviously more useful, diagnoses most of these fractures and dislocations. The flex sign is also more easily seen on a CT. And nowadays, weight-bearing CT scans are possible, and those are advocated to diagnose subtle instabilities. MRI, again, more useful in a subtle, unstable situation to diagnose the integrity of the plantar and the interosseous LISFRANK ligament. A signal change or a ruptured plantar ligament is diagnostic. And like I said, it's more sensitive for pure ligamentous injuries. In fact, there is a algorithm based on MRI for subtle or pure ligamentous LISFRANK injuries. So if it's a grade 1 or a grade 2 sprain, do a stress radiograph under anesthesia. If it's stable, then you can manage them non-surgically, but if unstable, then or a completely torn ligament, then surgery, even if it is a pure ligamentous injury, is described. Thank you.